Hello friends, we will be discussing about hypertrophic cardiomyopathy in this video. So as we have already discussed, cardiomyopathy means it is a heterogeneous group of the diseases which result from abnormality in the myocardium. So it can be either the contractile abnormality in the myocardium or it is abnormality in the contraction due to the electrical dysfunction. So any of this, either the mechanical or electrical dysfunction which results in inappropriate ventricular hypertrophy or the dilatation, all that diseases will come under cardiomyopathy. So this has basically been classified as primary cardiomyopathy or secondary cardiomyopathy. Primary is, as the name suggests, it involves primarily the heart muscle only, whereas secondary cardiomyopathy means heart is involved as a secondary, as one of the organ in the multi organ disease. So it is secondary to the systemic disease which is involving many organs. Then it becomes a secondary cardiomyopathy. Or primary means if it only involves the heart, primarily it involves the heart itself, then we call it as primary cardiomyopathy. And depending upon the clinical, functional and pathological patterns, it has been classified as dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. So dilated cardiomyopathy means, as the name suggests, the heart chambers are dilated and the heart is enlarged and it is flabby. Whereas the hypertrophic cardiomyopathy, we have hypertrophy of the left ventricular walls, but the hypertrophy is irregular. The septum is, interventricular septum is more hypertrophied when compared to the free ventricular wall. So it is asymmetric involvement. And restrictive cardiomyopathy is, here the heart, the muscle thickness is normal only, but the thing is there is some infiltration in the muscle wall so that the muscle does not contract or it does not dilate. There is a restriction to the activity of the muscle, so that we call it as restrictive cardiomyopathy. So in these three types of the cardiomyopathies, the dilated cardiomyopathy is the most common one and the restrictive cardiomyopathy is the least frequent one. So mechanism of the heart failure, and what about the ejection fraction? When we see the dilated cardiomyopathy, ejection fraction, left ventricular ejection fraction is less than 40%, and here the mechanism of the heart failure is systolic dysfunction. So dilated means, as I told you, the heart chambers are all dilated, so filling is more, but the muscle does not have that much strength to pump out all the blood. So it is a systolic dysfunction, and we have a group of the diseases which can cause this. There can be genetic cause, alcoholism can cause, peripartum, myocarditis, hemochromatosis, chronic anemias, doxorubicin, Chagas disease and idiopathic. All these causes we have discussed in the video about the dilated cardiomyopathy. Then hypertrophic cardiomyopathy, the ejection fraction is 50 to 80%, whereas in the restrictive it is 45 to 90%. And in both of them, the mechanism of heart failure is diastolic dysfunction. Then causes of hypertrophic, we have genetic causes, Friedreich's ataxia, storage disorders are there, certain syndromes are involved, and this condition we also see in the infants of the diabetic mother. Whereas the restrictive cardiomyopathy we see in certain infiltrative diseases and certain infectious diseases. We have amyloidosis, radiation-induced fibrosis, or it can be idiopathic also. And there are many other causes. This we will discuss when we are talking about the restrictive cardiomyopathy. So coming to the topic proper, that is hypertrophic cardiomyopathy. Now in this condition we have the myocardial dysfunction, which is due to asymmetric hypertrophy of the interventricular septum and left ventricular wall. Why they are calling it as asymmetric is, if you see here, the thickness of all the heart chambers, the heart muscle is not uniform. The entire heart is not uniformly hypertrophied. Instead, we have that interventricular septum, it is more hypertrophied when compared to the left ventricular wall. So there is some asymmetry in the hypertrophy. That's why they call it as hypertrophic cardiomyopathy is asymmetric hypertrophy of the interventricular septum and the left ventricular wall. So what happens when there is a hypertrophy is, so as the thickness increases, the volume of the chambers decreases, and when the volume of the chambers decreases, there is less filling of the left ventricle, and when there is less filling of the ventricle, that is less diastolic filling, what happens? Obviously the pumping out of the blood is also reduced. Along with that, there is a thickening of the interventricular septum, which causes intermittent ventricular outflow obstruction. So both this, you have a decrease in the diastolic filling and there is increase in the obstruction of the outflow. Both causes reduced stroke volume. So that causes the cardiac failure. This is the cause of the cardiac failure in the hypertrophic cardiomyopathy. And what is the etiology of the hypertrophic cardiomyopathy? We have the etiology has been divided into 4 headings. The first one is the genetic causes. Here we have the mutations which are involving the genes which are responsible for the sarcomeric proteins. And then we have storage disorders, mainly the lysosomal storage disorders like Gaucher's disease, Pompe's disease, and Fabry's disease. And then we have mutations which are involving the mitochondrial genes. In that, 2 important ones are the Friedreich's ataxia and the Mela syndrome. Friedreich's ataxia is, in this condition you have degeneration of the spinal cord and the peripheral nerves, whereas Mela's means we have mitochondrial myopathy. E stands for encephalopathy, LA is for lactic acidosis, and S is for stroke-like episodes. So these 2 are the mutations in the mitochondrial gene. Next, we have certain syndromes also, where we have hypertrophic cardiomyopathy. We have 3 syndromes: Leopard syndrome, Noonan syndrome, and Costello syndrome. So in the Leopard syndrome, the patient will have lentigens. Lentigens means you have a pigmented patches on the body. Lentigens there. ECG abnormalities the patient will have. Ocular hypertelorism. Ocular hypertelorism means it is a widely spaced, the space between the 2 eyeballs is very wide. Then the patient will have pulmonary stenosis, abnormal genitalia, retarded growth, and deafness. Then in the Noonan syndrome, there is a heterogeneous phenotypic manifestation with the wide set eyes, low set ears, short stature, and pulmonic stenosis. In Costello syndrome, we have mutations in the HRAS gene, which is affecting the heart, muscles, bones, skin, brain, and the spinal cord. So these 3 are the syndromes where the patient will have hypertrophic cardiomyopathy. So when we see the individually the genetic causes, as I told you, genetic causes means it is the genes which are involving, which are responsible for the production of the sarcomeric proteins. Now what are those genes? Are genes encoding for beta myosin heavy chain, then the myosin binding protein C, troponin I, troponin T, and alpha tropomyosin. So the genes which are encoding for these proteins, they undergo the mutations, then it leads to hypertrophic cardiomyopathy. And specifically the type of the mutations which are responsible are the missense mutations, and these mutations, they are inherited in the autosomal dominant pattern. So it's an autosomal dominant pattern of the inheritance. So the mechanism here is not completely understood, but it is thought that it is because of the defective energy transfer from its source of the generation to its sites of the use, that is in the sarcomeres. So in the if you see in the DCM, it is mainly associated with abnormalities in the cytoskeletal proteins, but here the abnormality is in the energy transfer, and mutations in certain genes, they give rise to hypertrophic or the DCM. If the type of the mutations, it depends. The same gene can be involved in both the DCM, dilated cardiomyopathy, and hypertrophic cardiomyopathy. But whereas in the hypertrophic cardiomyopathy, the type of the mutation we have is missense mutations. So we have the same genes involved in different type of the mutations, and then we have 2 different type of the diseases can manifest in this. And in the storage disorder, what happens is usually the substrate will be ingested into the autophagosome, and then this phagosome will combine with the lysosomes, and the lysosomes will release their enzymes into the phagolysosomes and they digest the substrates. So if there is any defect in the lysosomal enzymes, then what happens? A substrate which has been ingested cannot be digested by the lysosomal enzymes. So all the substrates start accumulating within the cells and the cell will slowly increase in the size. So when the cells increase in the size, obviously the organ also increases in the size. So in that way we have the hypertrophy, and in these conditions in the hypertrophy there will be abnormality in the electrical conduction if the interventricular septum is involved, and because of the back pressure there can be biatrial enlargement and there will be papillary muscle hypertrophy. Later on, after some time, each cell will undergo the necrosis. Then there is a myocardiocite degeneration, and after necrosis we have the fibrosis. So that causes the restrictive cardiomyopathy. Now, so we have seen genetic causes and we have seen lysosomal storage disorders. The third one is mutations in the mitochondrial gene related disorders. So when the mutations occur in this, the mitochondrial function is affected and there will be oxidative stress. So we have reactive oxygen species, more of reactive oxygen species, so that causes the stress and this leads to the myocyte dysfunction. So later on that leads to the hypertrophic cardiomyopathies. Basically in hypertrophic cardiomyopathy what happens is the sarcomeres they increase in the number and they are arranged parallelly. Now if you remember in dilated cardiomyopathy they are arranged in the series. Side by side they are arranged in the series. So the length of the myocyte will increase instead of thickness. Whereas in the hypertrophic cardiomyopathy they are arranged parallelly. So because of this there is increase in the thickness of the myocyte. Now when we see the morphology, as I already told you, we will have an asymmetrical hypertrophy of the interventricular septum when compared to the free left ventricular wall, and because of this thickness of the interventricular septum, the entire lumen of the left ventricle, it is compressed and it appears like a banana like configuration. Okay, so we have more of interventricular septal hypertrophy when compared with the left ventricular free wall hypertrophy, and we have a banana like configuration of the left ventricular lumen when we see in the longitudinal section. And typically what happens, this hypertrophy of the interventricular septum, it is more in the subaortic region. So when it is more in the subaortic region, the anterior leaflet of this mitral valve, it will be coming in contact with the interventricular septum whenever the ventricle contracts. So because of this, there is slowly the fibrotic thickening of this valve. And not only that, whenever the ventricle contracts, the valve comes in close contact with the interventricular septum. It causes obstruction to the outflow of the blood through the aorta. So we have a regurgitation into the left atrium because during the contraction the aortic opening is closed, so the blood regurgitates back into the left atrium, and as the blood flows very slowly through the small opening into the aorta, we get a crescendo decrescendo murmur in this condition. Then microscopically the change what we see is, if you see, these are the normal myocytes and this is the hypertrophic cardiomyopathy. So the size is increased. Normally we have 15 microns diameter of the myocyte. Here they can go up to the 40 microns, and there will be a disarray of the arrangement of the muscle bundles. Along with that, in between the myocytes we have the fibrosis, and because of the fibrosis there will be narrowing of the small arteries which are present in between the myocytes. So we have increased thickness of the myocyte, disarray of the arrangement, fibrosis, and compression of the arteries. Now the clinical features is, whenever there is a hypertrophied cardiac muscle, the thickened muscle, it cannot dilate. So there will be impaired diastolic filling. One thing is it cannot dilate, other thing is because of the hypertrophy the lumen is reduced in the size. So all these things they lead to impaired diastolic filling, and there is also obstruction to the left ventricular outflow, as I told you. Because the interventricular septum is maximum, it is thickened at the subaortic region. So whenever the ventricle contracts, this part comes, the subaortic region, the interventricular septum and the subaortic region, it comes in contact with the anterior mitral leaflet and the outflow is reduced. So both this, it causes decreased stroke volume. Then just the obstruction to the left ventricular outflow, it causes regurgitation into the left atrium, and that causes increased pulmonary venous pressure, which causes exertional dyspnea. Not only that, as the thickness of the muscle is increased, the blood supply may not be sufficient to supply the entire muscle. So it can undergo the ischemic change. So the patient can develop the myocardial ischemia also. So then later what happens is the patient can develop atrial fibrillation. There can be a mural thrombus formation which can embolize later. Then intractable cardiac failure can occur. Ventricular arrhythmias can occur in this condition, and there can be a sudden death. This is the common cause of the sudden death in the young athletes. So if they give the history that young athlete has, there is sudden death of the young athlete, then you should think of hypertrophic cardiomyopathy. So what is the treatment of this condition? Either we can use implantable cardioverter defibrillators if there is any conduction defect, or there should be a surgical reduction of the mass. So that finishes, and when we summarize, first we have to see what is the definition. It is asymmetric hypertrophy of the interventricular septum and the left ventricular wall. Then the causes, we divide them mainly into the four subheadings. Genetic causes, that is the missense mutations which are involving the genes encoding for sarcomeric proteins. Then we have lysosomal storage disorders like Fabry's disease, Gaucher's disease is present, and Pompe's disease. And then the mitochondrial gene mutation disorders, we have Friedreich's ataxia and the Mela syndrome. And malformation syndromes, we have Leopard's, Noonan and Costello syndrome. Then when we see the morphology, there is an asymmetrical interventricular septum thickness will be there when compared to the left ventricular wall. The muscle, the myocytes are hypertrophied, there is disarray of the arrangement, interstitial fibrosis will be there, and thinning of the arteries will be present. So what are the clinical features? The patient will have reduced stroke volume, patient will have back pressure in the left atrium and then into the pulmonary vessels causing exertional dyspnea, and because of increased thickness patient can develop the myocardial ischemia. Then later on he can develop atrial fibrillation, arrhythmias, patient can develop the thrombus, there can be cardiac failure, and sudden death can also occur. So that finishes hypertrophic cardiomyopathy. Thank you friends, thank you for listening patiently.